All right, well, I think we can go ahead and get started. Hello, and welcome to Health Equity and Policy Implications 2025 Changes in Medicare and M3P, presented by Deneen Ciccone and Audrey Davis. My name is Gabby Bernardo, Manager of Partner Data and Communication at Cancer Support Community, and I will be moderating this session. Before I introduce our speakers, I want to review a few housekeeping items. First, this session is being recorded and will be available for viewing after the event. However, continuing education credits can only be earned by attending this live session. If you wish to receive a continuing education credit from participating in the session, you must complete an online evaluation form, the link to which will be made available at the end of the symposium later today. If you would like to ask a question during the presentation, please do so using the Q&A feature in Zoom. Questions will be addressed at the end of the presentation. To turn on closed captions, please click on the CC button in the Zoom toolbar below. Now I would like to introduce our presenters. Audrey Davis has over 10 years of direct, supervisory, and administrative experience, is a licensed professional counselor and a certified grant proposal writer, and is certified in project management lean process. She enjoys presenting CSE's work on medical mistrust, enhancing care for historically under-resourced patients and caregivers, exploring innovative and sustainable solutions to ensure that each person impacted by cancer has access to the care that they want, need, and prefer. Audrey has also been sole and second author in peer-reviewed journals involving faith and healing. She attended Central High School in Philadelphia, Pennsylvania, before completing her undergraduate studies at Carleton College in Northfield, Minnesota. Audrey later attended graduate school in St. David's, Pennsylvania at Eastern University. Most recently, she created and managed programs and projects that address the social and structural determinants of health, with specialized attention to the intersection of behavioral wellness and physical health outcomes, Currently, alongside a plethora of teams at CSE, she is initiating programs to improve clinical trial understanding, representation, and diversity, increase trust in the medical community, and improve diversity and representation in grassroots policy advocacy efforts. As Vice President of Policy and Advocacy at Cancer Support Community, Deneen leads policy and advocacy efforts and advances initiatives that ensure that the voices of patients, caregivers, and survivors continue to shape policymaking. Deneen envisions a healthcare and social system grounded in equity for people impacted by cancer by addressing and solutioning for social and healthcare factors. Prior to joining CSE, Deneen served as the staff lead for the Multi-Cancer Early Detection Consortium's Health Equity Work Group and led the policy and advocacy team for the Coalition to End Social Isolation and Loneliness, where she provided strategic direction and policy analysis on issues including mental health, caregivers, and social connection. She also served as Director of Healthcare Reform Policy at the American Speech Language Hearing Association, where her efforts led to patients gaining access to habilitation and rehabilitation services and receiving in every health insurance plan's summary of benefits and coverage, the details of what services are covered and how many are covered. In addition, Deneen worked to promote and protect the healthcare rights of all patients and caregivers by ensuring that individuals with limited English proficiency and individuals with disabilities had the availability of language assistance services and/or auxiliary aids and services to enable them to identify themselves, participate in, and understand their healthcare. Please welcome Audrey and Deneen.
Thank you so much, Gabby, for that wonderful introduction, and good morning to some of you and good afternoon to others. Let me go ahead and get this slide advanced. A few disclosures that we have for you. So I do need to share that I have consulting relationships with both Pfizer and Bristol Myers Squibb.
And I'm disclosing that I have consulting relationships with Sandoz.
Now that we have that out of the way, just a quick overview of what our session will look like. I will give a very brief refresher on what health equity is, what health equity is not. I'll also talk a bit about mistrust and distrust, both in the healthcare space and also in the policy and government space. I'll then let you know what CSE's ideal program is and how it relates to M3P by passing it over to Deneen, who does lead our Cancer Policy Institute. She will give a more detailed overview of the M3P program and also how the benefit will work. And at the end, we will have time for Q&A. So as Gabby mentioned, please do use the chat feature in Zoom. So health equity, just as a refresher, when we talk about health equity, we really are talking about the health status of someone. We want to ensure that each person has a fair and just chance to attain their best health, regardless of phenotype or genotype, where they live, preferred pronouns, preferred language. Doesn't matter what sort of sociodemographic factors they have, that should not impact their ability to be healthy and at optimal health. And so we do this by identifying and addressing the disparities that exist between communities. We also prioritize those historically underserved, those historically under-resourced and medically underserved groups. And we develop and implement strategy alongside those communities to ensure that we also respect solutions that they've already come up with, the empowerment and the collaboration and communication that has already occurred within these respective communities, and building on that instead of trying to reinvent the wheel when we talk about how we can help folks. This is a graphic from the Robert Wood Johnson Foundation. I apologize, I didn't get that little text box in there, but what it's showing here is just a really helpful visual for health equity and how we conceptualize it. So some people might need a taller box, some people might need a ramp, some people might need a shorter box, but in order to have that access, and access is really what we're focused on when we talk about leveling the playing field, you need to ensure that accommodations are made and that different programs and solutions are tailored for different people. When we talk about DE&I, often in my work, I hear DE&I confused with health equity. It is not the same thing. They might be in the same family. Think of them as cousins. They're not twins. They're not even siblings. DE&I often focuses on workforce in most contexts. If you speak with DE&I specialists, some of you may have heard more about this in June of 2023, when the Supreme Court actually struck down race-based affirmative action in schools, and the ripple effect that this had on DE&I in the workforce and programs that are designed to increase diversity. And so when we talk about diversity, we're talking about having different and varying identities at the table, in the room. This doesn't only have to do with race and ethnicity, though. We're also talking about sexual orientation and gender identity. We can be talking about where someone is from, whether they're from a rural, urban, suburban area. Sometimes folks also like to talk about socioeconomic status and how certain people may differ significantly from the socioeconomic status that they grew up in, the household that they grew up in, and where they are now, and how that also brings diversity to the table in terms of perspective and lived experience. We're also talking, again, not only about race and ethnicity, but also about whether someone is an immigrant, if they're first generation, lots of different ways that we can define diversity, but keep in mind that this is not related to healthcare. It does help to have a diverse workforce when we're talking about attaining health equity. We know from our own research that racial and identity concordance are very, very important to patients and their loved ones. We know that when people in the room who are practitioners, who are navigators, who are on care teams look like the patients that are being engaged with, that it makes a difference to the patient. It also increases trust, and I'll get into that a bit more. But for now, diversity, just think about differences being represented. When we talk about equity, I heard someone recently describe this as thinking about money and reallocating power and resources so that any sort of inequities or differences that exist are mitigated. And then, of course, inclusion, right? Each and every individual matters. It's not enough to say that we're going to have a bunch of different people on our workforce or in the room. It's not enough to say that we're going to reallocate our resources so that we can maybe improve our recruitment efforts and strategies. We need to make sure that we're actually including the input and feedback and taking seriously the input and feedback of each and every individual in the room. And I like the highlight here of individuality, because we know that even with diversity, no one group is a monolith. In my community, we have a saying, all skin folk ain't kinfolk. What that means is just because someone looks like me, that doesn't necessarily mean that we share the same beliefs. We don't necessarily have the same lived experiences. We may not hold the same views. And so if you happen to have more racial and ethnic diversity, for example, but you're not taking into account the importance of having each individual's voice, you're going to lose a lot of the benefit that would have been gained if you recognize recognize that each person, each individual also needs to be seen for their respective experiences and voice. So when you have DE and I, often you will then the result that you'll have would be a sense of belonging and inclusion for the workforce, for that group that you're implementing these DE and I strategies with. And some of you have already heard of belonging, right? So DEIB, this sense of not only being included, but also I belong, right? As a result of the efforts to increase the diversity here, as a result of the reallocation of funds or resources, and as a result of the fact that my voice and my input has not only been solicited, but actually taken into account in planning, I belong here. I have a place here. One thing that I just do want to caution when we're talking about DE&I, because of the more recent Supreme Court ruling last year, this ripple effect that I mentioned earlier in terms of lawsuits now happening to address DE&I policies in the workplace, we're seeing affirmative action being challenged in the workplace now and DE&I language being discouraged. Some organizations are starting to use the term inclusive excellence instead. I won't give my personal opinions on the terminology that is being used or not being used. What I will share and the takeaway that I want everyone to remember from this session is that health equity is not DE&I. They have some overlap. It is important to have one DE&I in your workforce in order to enhance health equity for patients, but they're not the same thing. I also just want to take a moment to recognize the cancer disparities that do exist when we're talking about making the inequitable equitable. And again, this is not just based on race or ethnicity. For example, when we talk about certain cancer types and their prevalence, incidence, and mortality rates, women in rural areas are actually twice as likely to die from cervical cancer as women in more urban areas. Thinking of folks on tribal land, the highest rates of kidney cancer cases and death in the United States occur among American Indians and Alaska Native people. And then you see some of the other statistics here. And I'm mentioning this because it connects not only to the conversation on health equity, but also to the conversation on medical mistrust. And so we define medical mistrust when considered the disparities that I just mentioned as a protective response, right? We're talking about systems here. We're talking about longstanding structural inequalities that have resulted in, again, there's that word access, restricted access to resources, things like housing, childcare, healthcare, education, employment. And this is compounded with the daily experiences, this contemporary experience of racism, stigma, and discrimination. Justified medical mistrust today looks like biases in healthcare, right? We have implicit bias, which negatively impacts patient-provider interactions. And when I'm talking about implicit bias, what I'm talking about is assumptions that the provider is making based on just looking at the patient. When they walk into the room, everyone carries some sort of bias with them, but a lack of willingness to acknowledge that, the inability to be culturally humble or seek training and cultural competency then contributes to these negative patient-provider interactions. It also contributes to less likelihood that the patient might be interested in joining a clinical trial or keeping up with their appointments. We also are aware of confirmation bias in healthcare and how this plays a role, right? And so if I have a patient who is presenting, let's say, with pain in their lower abdomen, and they identify as a woman, and you know, I might be thinking based on my own likelihood of diagnosis that this patient is probably experiencing fibroid pain. And so, yeah, I'm going to go ahead and confirm this as fibroid pain. I may not order blood work to rule out that this could be related to a blood cancer or some other condition because of my own biases in how this particular patient looks and this particular patient is presenting. And then we also have the availability heuristic or availability bias. This often leads to misdiagnosis. And this just means that the provider is more likely to weigh certain information that's available to them based on prior experience. So if I'm always seeing people with chest pain in the ER and I'm ordering scans because I'm concerned about heart attack or something in the lungs, I may be missing that this is also symptomatic of other diseases and conditions. And then this not only leads to misdiagnosis, but a delayed diagnosis as well. Quick caveat, mistrust, because these sometimes get confused. When we talk about medical mistrust, it's a general, like intuitive kind of lack of faith based on discomfort that you have with the healthcare system, maybe with big pharma overall, right? Not wanting to participate in a clinical trial, not because of any one particular reason, but because you just don't generally feel comfortable. Whereas distrust is a lack of faith based on actual knowledge or experience. So if Dr. Jones walks into the room and they have their eyes and their tablet the whole time, never once make eye contact, are very dismissive of my complaints about pain, they seem to be insinuating that I'm malingering or that I'm med seeking, I now am distrustful of Dr. Jones based on my actual experience with them. It's not just a general, I don't know about Dr. Jones. I have concrete evidence to that. Now we move into more of the policy discussion. So we know that medical mistrust exists, but we also know, as we see in this graph from the Pew Research Center, that over time, public trust in government has also decreased, and it's near, as stated here, historic lows. Back in the 1960s, I'd say well over 70% of folks felt that that their government leaders would do what was right just about always or most of the time. And now we are in the 2010s, 2020s, looking here, excuse me, and we're hovering right around 20%. When you don't have trust in your government, you're less likely to participate not only in the political process, but also you're less likely to feel that your policymakers actually care about your experience. You don't necessarily think that they're going to do what's right because you maybe have seen evidence otherwise, or maybe it's just a general sense. And so to address some of this mistrust and distrust of government, and to also ensure that the patient voice and the voices of loved ones are heard on Capitol Hill and in policymaking spheres, we've created the Increasing Diversity and Equity Through Advocacy Leadership Program, also known as IDEAL, and good for an acronym. And so through this, we train diverse cohorts of patients and loved ones in grassroots policy advocacy. And so when I talk about diverse, in this context, I'm talking about community members from the Black and African American community, Hispanic and Latino, Spanish-speaking, monolingual, and bilingual, and also folks from rural communities who are often forgotten about when we have policy-making conversations. We offer education not only about local, state, and federal policy advocacy, but also very clear, actionable steps that help these ideal ambassadors to engage in advocacy in a way that feels authentic and comfortable for them. If you're an introvert, there are ways that you can write letters and send emails. If you're an extrovert and you want to go to a Hill Day and you won't be drained by it, then we will tell you about different Hill Days that either CSE is engaging in or ways that we can organize one. We also are careful to empower individuals and enhance communication networks that they already have in order to impact change. Really, the model here is each one teach one. Once one ideal ambassador gets trained in the program, our hope and our vision is that they will then go back and talk to their care partners, their loved ones, people in their community, and say, hey, this actually isn't so hard. It's not so nebulous. Advocacy is very much something that we can do, and we can do it together. With that in mind, I am now going to turn it over to Deneen. One of the policy or priority areas that we have involves attention to the IRA and Medicare Part D, and this is something that we also cover in our IDEAL modules. Deneen?
Yes, thank you. So good afternoon, good morning, everyone. I would like to kind of share some new changes that are going to come into effect starting next year. And as Audrey mentioned, the Inflation Reduction Act is one area that I'd like to talk about. You know, you may have heard about the IRA, as they call it for short, with respect to Medicare prescription drug prices. You may have heard about, you know, the $35 insulin cap to save patients on paying for their prescription drugs. You may have also heard about the 10 drugs that were recently negotiated by the federal government and some manufacturers. Those top 10, one of the drugs was a cancer drug, Imbruvica. But there were also other changes to kind of help with the affordability of Medicare beneficiaries affording their prescription drug coverage that we'd like to talk to you about. And one of those that goes into effect starting January 1 is called the M3P, which is the Medicare Prescription Payment Plan. And what that does, starting in January 1, Medicare enrollees that choose to opt into this can pay for their medication and zero interest monthly payments. And so what that means is that instead of paying for the cost of the drug at once at the counter, they can pay directly to their Part D sponsor or their health plan, for example, in monthly payments to improve the affordability. So these things I'm talking about, it's all about improving the affordability for Medicare prescription drugs for Medicare enrollees. That's number one, M3P. Number two is that the IRA also establishes a maximum out-of-pocket limit for Part D drugs starting next year, which is $2,000, meaning Medicare enrollees, whether you enroll in the M3P or not, a Medicare enrollee in Part D cannot pay more than $2,000. What is also interesting and is an exciting opportunity with respect to expanding access and affordability is that the IRA also expanded how beneficiaries or enrollees, as I like to call them, may be able to participate in what is called the low income subsidy program. And I'll talk about that more in the next slides. When you look at this slide, it kind of breaks down a little bit how, through the IRA, they close what's called that coverage gap or that donut hole, and saying that once you hit $2,000, that's the maximum that any Medicare Part D enrollee will pay out of pocket. Next slide. And so how does the M3P work? That's the question that we get a lot. This is a brand new program. How does this work? And I should just step back and say we're doing this because we recognize this is a brand new program. And so a lot of Medicare beneficiaries and their caregivers may not know that starting in open enrollment in October 15th, which is on Tuesday, they have the option to discuss whether or not they want to enroll in this program. So as I mentioned, Part D enrollees, they have the option to enroll in M3P. It is not by any means mandatory, but they have the option if it is determined that it makes more sense for them financially to spread out the costs of their Medicare prescription drugs in a monthly installment. And so the installments work through a calendar year, not a fiscal year. So it's from January to December of 2025, for example. And as I mentioned earlier, that, having this M3P can really help and really pay for costs where they may have otherwise said, you know what, I can't afford this treatment. I'm going to just skip it altogether. This may helpfully encourage them to take that medication, to have that medication adherence and to really help improve their outcomes. And so one example that we like to talk about here to kind of make it, make sense for people is, say, for instance, someone has a $1,000 in out-of-pocket cost in March. They can pay monthly installments of $100 from March to December instead of having to pay $1,000 at the point of sale, meaning at the pharmacy counter, for example. Next slide. And again, the Medicare Part D out-of-pocket maximum, just to kind of say, again, these are two separate programs. I really want to press that. If there's nothing else to remember, M3P is one. To me, I look at that like monthly, a zero interest monthly payment, right, that you can make. And number two is the maximum out-of-pocket cost of $2,000 a year. And so we're pressing this because, like I said, these are new changes. These are exciting, potentially exciting changes to Medicare beneficiaries. And we want to, explain it in as easy as way as possible, because we anticipate that Medicare beneficiaries may have a lot of questions, and their caregivers, particularly as we are about to approach the open enrollment period. Next slide. And so I mentioned at the outset that there's another program. It's not brand new, but what the IRA does is it expands Medicare enrollees' eligibility to participate in the low-income subsidy program, which is also known as the Extra Help program. So this program is actually different from M3P. Remember, M3P allows you to have a monthly installment of paying the overall cost of your Medicare prescription payments. What the Extra Help program does, it actually reduces a Medicare beneficiary's out-of-pocket costs by lowering their premium for Part D and their cost sharing for medications. But this is based off of income eligibility. And so what the IRA did for this year, starting in 2024, they expanded the income requirements or the income band up to 150% of the federal poverty line. So if a Medicare Part D enrollee, for example, if you look at this slide, they make less than $22,590 per year for a single household, or less than $30,660 per year as a couple, they may qualify. But again, they would have to contact Medicare and complete the paperwork to determine whether or not they are eligible. And again, this is really important that we help spread the message about this, because what we do know is that there are probably millions of Medicare beneficiaries potentially who are eligible for this extra help program, and they don't know that they have this option available to them. Next slide. Thank you. So if you are speaking to someone or their family member, for example, and you tell them about the Medicare prescription payment plan, because what is quite possible is they may not know that this is an option that's available to them, and that is a benefit that they have. So if in your conversations, and if you become aware that the treatment profile might be a little cost prohibitive, you could proactively, bring up this conversation and say, hey, I'd like to talk to you. Are you aware of some affordability mechanisms that might be available to you under the Medicare program? And if you do have this conversation and they'd like to know, well, how can I benefit, how can I opt into this? It sounds great. What do I need to do? You tell them what they have to do is they have to contact their Part D prescription drug plan insurance provider directly. They can call them over the phone, or they can opt in online. And they can opt in now during open enrollment, which is the easiest, but this isn't the only time. They can opt in at any point during the year, because remember, if they determine, as they're beginning to receive their medication needs, if their needs change throughout the year and they recognize, what, I think I really would like to take advantage of this monthly payment plan, they have that mechanism throughout the year, depending, on what their circumstances are, to say, I'd like to opt into this program. So it's, if nothing else, let them know. They contact their Part D prescription drug plans sponsor. They can do it at any point over the year. They can call, they can do it online. And once they're opted in, they don't pay for their medications at the pharmacy counter. Why? Because their Part D sponsor is going to send them monthly bills for the payments. Because what's happening is the Part D plan sponsor or the health plan is paying in advance. They're paying in advance to the pharmacy for those medications. And so what the Medicare beneficiary is doing is paying back, like I said, that zero interest loan, so to speak, to the Part D plan sponsor. And so what we like to always encourage Medicare beneficiaries that have decided to opt in and they think they'd like to do this, if they can, think in advance, it would be ideal, right? Ideally, you'd opt into this program in advance, at least 24 hours, before picking up your medication, but that's not required. They can actually contact. Now, practically, this may not make the most sense because, this is a brand new program. So there may be some tweaks and improvements once we get some more, user experience. But what they could do technically is at the actual pharmacy, they could actually tell the pharmacist, you know what, I want to opt into the Medicare prescription payment plan. But what they have to do, which isn't the most user friendly, they'd have to step outside of the line, right? Call their Medicare Part D plan sponsor and say, hey, I'm at the pharmacy counter right now. I'd like to opt in. They have that option that they can do that, and then they can take their prescriptions. That's why we say, to make it a little easier, if they could do it in advance, at least 24 hours, that would, remove that necessity to go through that hassle at the pharmacy counter of getting out of the line and calling their Part D sponsor. But I do want you to know that if they choose to do it at the pharmacy counter, they have that option as well. So although it says here that you cannot sign up at the pharmacy counter, what that means is, by law, pharmacists are not required to tell Medicare beneficiaries about the Medicare prescription payment plan. That doesn't mean, however, that a Medicare beneficiary who's just like really well versed and aware of what's out there, they can go to the pharmacist and say, you know what, I want to participate in the Medicare prescription payment plan, so I don't have to pay for the the prescription drugs at this time. Next slide. And so what we like to do, which might also be helpful for you in your conversations, I would encourage you, if helpful, to download the slide deck, maybe print out some of these commonly asked questions that we may receive that can help you in your conversations. These are just some of the questions that we have received or anticipate receiving. Our financial navigators also, they've already started fielding some calls and questions from Medicare beneficiaries and their caregivers about participating in the M3P. So some commonly asked questions that you might get, I would look at this as a cheat sheet. Who is most likely to benefit from M3P, right? And so CMS, that's the Centers for Medicare and Medicaid Services, they're the ones that are overseeing this program. They've anticipated that if one medication is likely to cost at least $600, that a Medicare beneficiary is likely to benefit from enrollment in the Medicare prescription payment plan. If individuals are participating in other programs like Extra Help, for example, the M3P may not be the best option, because remember, the M3P does not reduce your costs, it spreads it out. Whereas the Extra Help program is actually reducing Part D premiums and cost sharing, such as a copay, for example. I would also recommend that if you'd like to refer the Medicare beneficiary to someone else, for assistance with respect to, is the M3P right for me? You can recommend they talk to a patient navigator, call their Part D sponsor, which is their health plan, and they can, of course, contact our helpline for questions. As I mentioned, our financial navigators are actually having appointments now, and we are fielding these questions in real time. Again, just to reiterate, will an enrollee have to pay more than the annual $2,000 out-of-pocket limit if they opt into the Medicare prescription payment plan? No, because remember, the annual maximum out-of-pocket cost for prescription Part D drugs in 2025 is $2,000. That's for all Medicare beneficiaries. The third question that you might hear, or that we believe comes up quite a bit. Okay, so what if I opt in and then I decide, you know what, M3P is not really right for me? What can I opt out? The answer is yes. Enrollees can opt in at any time, and they can also opt out at any time. However, they are still responsible for any remaining balances to their prescription drug plan to their Part D sponsor if they choose to opt out. And so that balance can either be paid all at once, or they can continue the monthly installments. And once they're disenrolled, any additional drugs will be paid directly to the pharmacy. So if nothing else, you can opt in at any time and you can disenroll at any time. Again, CMS wants to continue to empower Medicare beneficiaries by saying you make the choice that is right for you. And they also understand that circumstances change. So at one point it might make sense, and then in the future it might not, and vice versa. Next slide. A few other commonly asked questions that we wanted to impart with you all is, someone might say, well, what happens if I miss a payment, right? Or if I'm late? So there is a required 60 calendar day grace period after the due date for a Medicare beneficiary who enrolls in the Medicare prescription payment plan to make up their missed payment. If an enrollee misses a payment and they don't pay after the 60-day grace period completely, they can no longer participate in M3P. So they will be disenrolled, and they will start to pay the pharmacy directly for future drugs. They will still have insurance coverage. So one thing, even if they enroll in M3P and then for whatever reason they miss a payment, and or they've decided, you know what, I can't afford the monthly installment, they're not going to lose access to the Medicare Part D. And that might be another area that's really important to stress that you can enroll in M3P. Whether you stay enrolled or you disenroll, you're not going to lose coverage to the Part D benefit that you've enrolled for, because M3P is an option. And so what also happens is, if, say, for instance, that they miss payments and they get disenrolled, or their payments are late, they can still opt in again to the M3P program once they repay what is owed at the time of disenrollment. So I think what this really shows is that CMS is being a good steward and saying we want to remain flexible, and we really want to provide as many opportunities as possible to make this program work for Medicare beneficiaries. And so lastly, what else should Medicare enrollees be on the lookout for during open enrollment, which starts on Tuesday? Any changes in their benefit design, whether their drugs are on formulary or not, and whether their prior plan is still the best prescription drug plan for them moving forward. And so a lot of times we say they can go to the Medicare prescription drug plan finder to kind of look up this information, and they can determine in advance, right? If they go to the Medicare website and go to the prescription, the Part D plan finder, they can put in their insurance, their Part D insurance information. If they know the drugs that they're on, right? So this requires you to kind of know, I'm on like this might be maintenance therapy, or I'm on continuous treatment. They can look and see whether or not the drugs remain on the formulary, because what we do know is that oftentimes it's not uncommon that a drug might be on a formulary at one point in time, and then it can be taken off formulary. So this is just a way, it's not to put the onus on the patient or the caregiver, but it's to empower them and to let them know that they do have a role in this, and that if they want to be proactive, they can go online and go to the Part D plan finder to see if the current plan they're in, if it still works for them, If there are any changes in the benefit design, that's like utilization management, that's like step therapy requirements, or that's like any other prior authorization requirements, and whether or not their drug is still on formulary, and if there are any limits related to access to that medication. Next slide. And so with that, I wanted to share some additional resources that we have on the Medicare prescription payment plan. This really is a group effort. I always like to say for this, it takes a village, because the patient advocacy community, we recognize, irrespective of the diseases that we represent, that this is a new option for many Medicare beneficiaries, and they don't know that it's available. And so what we want to do is we want to use as many media and opportunities as possible to spread the word about this potentially really exciting offering in the Medicare program that can really help with affordability. And so there are a couple of offerings that CSC has. One, if you look in the our resources at the beginning of the webinar, I believe there's a tab with some resources. There is a link to our patient and caregiver focused webinar on the Medicare prescription payment plan. It's at the end of the month from 6:30 to 7:30. Again, as you can see, the focus of the audience is patient and caregivers. So we want to put this in plain language to really help them understand, and it's still within the open enrollment period, so they still have time. We are partnering with OncoLink, and this is being made possible through the generous support of one of our partners, Takeda Oncology. We have also created an educational FAQ blog that which has also been shared in our resources, that I encourage you to take a look at. It's our financial navigators who did a really good job kind of explaining like a 101 or the nuts and bolts of what the M3P is, reiterating a lot of what you heard us just talk about, but repetition often helps a lot with understanding new information. And we also have a dedicated webpage forthcoming on the M3P, so continue to check back our website for when that information is available. So that's what we're doing at Cancer Support Community. But like I said, this truly takes a village, and we're not the only ones. So some additional resources we wanted to share is that the Centers for Medicare and Medicaid Services, they've actually created their very own Medicare prescription payment page, homepage, that I encourage you to bookmark potentially, so you can check it frequently to see if there's any updates to the program or get the latest information from CMS. Another patient advocacy focus group, the Alliance for Aging Research, they have also created some resources on the program's impact on patients. I thought I said the webinar is on October 29th. My apologies if I didn't, but yes, the slide says October 29th. So thank you if I misspoke. And then I also mentioned the CMS also is working on creating an estimated monthly payment calculator that I would encourage you to look at, and you also share with any patients or caregivers who may want to know, hey, does it make sense for me to enroll? It will basically help them estimate what their yearly cost might be for participating in the Medicare Part D program. And then lastly, there are state health insurance assistance programs, SHIP Help, that are also out there as well as a resource. So as I mentioned, this is going to be 2025 is the first year, right? So this is going to be a learning opportunity for us, for you, and for the patients and the caregivers as well. And I anticipate that this will be an opportunity for us to kind of learn how people are enrolling. Do they understand how it's enrolling? Is it working for them? And there may be mechanisms to improve the program to make it more user-friendly for Medicare beneficiaries and their caregivers as well. So with that, we can go to the next slide. I believe we are at questions, and I know I just gave a lot of very technical policy information there, and I'll give you all a chance to digest that. But Audrey and I wanted to make sure we left enough time for conversation and discussion on anything that we talked about. So with that, I'll turn it back over, or just open it up to the group and turn it back over to Audrey.
Thank you, Janine. Gabby, I'm not sure if you have been able to sift through the chat, but I'm ready to answer if there's anything for me.
Yeah, if anybody has any questions, please feel free to enter them in the Q&A feature. It should be at the bottom of your Zoom toolbar. So far, we don't have any questions in the chat. But again, if you have a question now, please feel free to enter them in the Q&A section too. And we'll give it a minute.
I just wanted to respond. I saw someone left a comment in Chicago and saying that, thank you for your kind words, that Audrey and our blessings. I do want you to know, we're passionate about this. And just Chicago, I'm mentioning you in particular, we Cancer Support Community through Gilda's Club Chicago, we actually coordinated with Congressman Davis to do a Medicare prescription payment plan outreach effort in the community for the west side of Chicago, because many of his constituents are older adults, and he really wanted to help them understand some of the real benefits that were afforded to them through the IRA. And so we used that as a mechanism to be that community resource in the west side of Chicago to really kind of get that message out there. So thank you. And I also wanted you to know that we are doing some work in the community as well.
Deneen, did you also want to mention CSC's invitation for Congresswoman Kelly?
Yes. Okay, Earl, I just saw that he's your godfather. That is amazing. Okay. So also, Audrey, speaking of Chicago, we just attended a roundtable on Tuesday. Our coordinator for the Cancer Policy Institute, we were invited by Congresswoman Kelly of Chicago to a discussion on clinical trial diversity and what CSC's legislative priorities were related to clinical trial diversity. And we had a really great conversation. That was built upon some of the great work that came out of the Congressional Black Caucus. We had a panel presentation that Audrey can talk to you about justified medical mistrust. And Audrey talked about mistrust at the beginning of our presentation, that really examined what some of those barriers might be to clinical trial participation, particularly among Black and African Americans. And I think through that convening that our health equity department really led and put together, we were invited to a roundtable discussion with Congresswoman Kelly to share what CSC's legislative priorities are related to clinical trial diversity.
Thank you. I'm seeing some hearts flying, some hearts in the chat too. It's all really good to see. We did get a question in the Q&A feature as well. So we have a question. Do you think any of the insulin cost caps will be available to children with type 1 diabetes?
So at this time, Medicare is primarily for adults age 65 and older, or for individuals with disabilities who qualify for Medicare under the age of 65. So I would say at this time, probably not. But that doesn't mean, right, healthcare, there's no crystal ball. In the future, potentially, but what I would say is at this point, it's primarily for Medicare beneficiaries, and those are typically in adults age 65 and older.
Thanks, Denise. No other questions yet. We can give it a minute or two. I think we still have some time left today too in this session. So more praises in the chat as well, and more clapping emojis and hearts. So that's all really nice to see. And Audrey put in her contact info as well as Denise's contact info in the chat too. Oh, and it's there on the screen now too. Thanks, Audrey.
If we have the time, if it's okay to just pose a question to be answered either in the chat or Q&A. How many people before this session were aware of the ins and outs of the M3P program? And I also see a raised hand, Gabby.
Yeah. I'm not sure if people are raising their hands as a way to kind of show.
Deneen, this is so nice. I obviously would be nice if more folks were aware of it, and if it was better marketed. I think it's unfortunate that pharmacies can't share the information with patients who will benefit from it legally. But I'm glad that you were able to offer such detailed, not only information, but I think the Q&A was particularly helpful.
No, thank you. But I do think this is an opportunity, right? Like I said, this is the first year in the rollout. I think there is an opportunity to improve the program by, requiring pharmacists as one of those points of contact for patients and caregivers to have that conversation. Absolutely. Okay.
We do also have a very brief survey. I don't know, Gabby, I don't want to take over. I don't know if it makes sense to, there it is. Okay, you're seeing a survey pop up on your screen if you don't mind answering it. This is a rating scale. I'm sorry if it's not clear here, so I'll just tell you. Likert scale, 1 being strongly disagree, 5 being strongly agree. So 3 is neutral, 2 is disagree, and 4 is agree. 5 is positive, 1 is negative.
And yes, Janice, I saw your question. Will the program on October 29th be recorded for later viewing? Absolutely. I'm certain that our webinar for patients and caregivers on M3P will be recorded for later viewing.
Danina, is there anything extra you can share about that future webinar? What in-depth information it might go into today that you didn't have a chance to cover, or what it might go into on the 29th that we just didn't have a chance to cover today?
So honestly, I believe the M3P webinar is probably going to reiterate a lot of what we went into today but the audience is for patients and caregivers, so it's probably going to be like in a lot of like plain language. I think not very different from what we did now. But it's just an opportunity to speak to the Medicare beneficiaries and their loved ones about it. So I suspect it will probably be very much the same information. So if you want to share that link with others that you might come in contact with or others within your network, I would encourage you to do so. And our financial navigators, I'm pretty sure, are going to be a part of that. And so they will probably go into more details about some like examples about like the actual costs, which I didn't really do because that's what they do. So they can probably like really walk through some of those cost scenarios to help patients and caregivers make that decision. So, Kelly, that's probably one area they'll go into a little bit more detail that I didn't do today. So, Medicare beneficiaries that want to sign up for the Medicare prescription payment plan to M3P, they can do that through their Part D plan sponsor, which is their health plan. They'd have to contact their health plan to enroll. Yeah, Medicare Advantage plans. Yes, this also applies to Medicare Advantage plans as well.
Okay, we're going to go ahead and end the poll. Thank you so much for participating. And if you're interested, the results are on your screen. Gabby, is there anything else that we can do at this time? Are there any more questions coming in?
I'm not seeing any other questions. So I think we can wrap up now.
Someone just in the chat, I don't know if I'm off in timing, said, what about Advantage plans? But I think you just mentioned that, Denise.
I did. Yep. I just answered that one. Yep.
Okay.
Yes. And then, yeah, I think we're good to go. Yeah, I don't see any other questions in the Q&A or in the chat. Oh, I saw a raised hand, but it quickly went down. So, all righty. Well, we're at the end of our time together, so thank you so much again, Andre and Deneen, for being with us today. As a reminder, this session was recorded and will be available for viewing on CSC's Zoom Events Hub and on CSC's Learning and Training Program website through February 10th, 2025. PDF versions of the presentation materials will be shared with attendees following the event. Please note that all session recordings and resources available after the event are for informational purposes only and will not be eligible for CEs. If you wish to receive 1 continuing education credit from participating in this session, you must complete an online evaluation form. The link to this form will be made available after every session, but please note that you will only need to fill it out once to claim credits. If you have questions about this CE activity, please contact Prime at the email shared in the chat. Again, thank you all for joining us for this session. Our expo will be opened shortly at 2:45 p.m. Eastern. Please join us and visit our sponsor, the Leukemia and Lymphoma Society, and our CSC booths with mylifeline.org and the Cancer Support Helpline here during our 30-minute break. To access the expo, please click on the expo button in the top bar once you are back in the lobby. Zoom will provide a tutorial on how to interact with the booths if it is your first time. We look forward to having you all join our next session discussing adolescent and young adult cancer survivorship in 30 minutes at 3:15 p.m. Eastern. Or 45 minutes at this point, but let's see. Any other? And then one question again in the Q&A really quick. Can you answer the Medicare Advantage question again, please?
Yes, it would apply to Medicare Advantage plans as well. Yes.
Awesome. And then somebody asked a question about a code that's needed for the evaluation. The code is in the chat as well for you to access. All right. I think that's our time today. Thank you again, Deneen and Audrey, for joining us today. And thank you everyone for joining this session.
My pleasure.
Pleasure. Bye, everyone.